my privilege to invite Dr. Vanita Arora for the talk on leadless pacemaker. Vanita has been a dear colleague and I've known her for a couple of decades, very dynamic, and in terms of the advances in electrophysiology, be it pacing, ablation, she is always in the forefront. Vanita, eager to hear you on the leadless pacing technology.
Thank you so much, sir. It's always nostalgic and really, I get goosebumps when I come to Mumbai. And I thank Dr. Pehla Jani sir, Dr. Satyavan Sharma sir, Dr. S.B. Gupta sir, and of course Dr. Bora sir to have me at this AOC symposium. My responsibility today is to talk on leadless pacemakers. It's a total different modality of pacing than what you have been hearing in the last two talks. And at the onset of my talk, I will say that this modality is not meant for all patients. You have to very selectively select your patients, and there are two reasons. One is the cost. Second is that conduction system pacing, since we have been discussing about that, we are talking of physiological pacing. So this is as of now, it is not close to the physiological pacing, but it is a very good modality of choice for pacing in a very selective patients. So this is how this leadless pacemaker looks like. It's like a capsule. This is our conventional way of pacing that we have been doing for years. But over the years, we all have seen patients coming up with these problems to us. Either we have pocket infections, we have erosions, we have lead fractures, we have insulation breaks, and these patients, they come back to us and they are in a misery. They end up spending fortune on getting the treatment done for their infection, for their lead fracture, for extractions, and we have been looking for better outcome for these patients, and hence the concept of leadless pacemaker, to go away from the lead and to go away from the surgical pocket that we have to give these patients to implant a pacemaker. So this everything has been compressed into a small capsule, which is of course it is MRI compatible, 100% pacing. It lasts for about 10 years, and it is a small capsule which is around 2 grams of mass, which is placed in the right ventricle. So when we are doing this, we select the sheath. This sheath, it has an inner diameter of 23 French and outer diameter of 27 French. The axis is taken through the right femoral root, and this sheath is introduced in the right femoral root. We have to dilate
it's a free access
so that we can introduce this 27 French. Gradual dilatation helps us to make the placement of this sheath in the IVC, and I just generally go up to IVC or mid-RA to place this sheath and
dilate the vein. Capsule micra is mounted.
This is how the leadless pacemaker catheter looks like, and this catheter has leadless pacemaker mounted at one end.
This is the leadless pacemaker, and on this catheter there are 3 knobs. One is the deployment knob, the other is the deflectable knob, and this third green one is the locking knob.
And it is holding, if you on the distal end by the tethers. So we place the stiff wire in the SVC as we do when we are doing BMB, and then we take the sheath in, place it in the mid-RA. Following that, we take the micra or the leadless pacemaker, we insert through the sheath, and we go up to the level of mid-RA. Once we reach with the leadless pacemaker to the mid-RA, we pull down the sheath to the IVC, because it's only one curve of the leadless pacemaker which is there, and it works better in case you have the sheath in the IVC. So we use the deflectable tool to give the sheath the curve, and we cross the tricuspid valve, give it a clockwise twist, and go to approximating close to the septum. Once we have reached there and we are happy with the positioning, then what we have to do is actually take a dye shot to see for the trabeculae. Here you see I have taken the dye shots in 2 views. One is in the LAO, one is in the RAO, and we can see good trabeculae there. And once I am happy with the trabeculae, we release, we unlock the tethers, and then we release the leadless pacemaker into those trabeculae, and the tines, they hinge into the trabecally. And this is how it is released. And you can see some ectopics coming in the ECG. This happens because of the catheter there. And now this is the most important step of the knowing that leadless pacemaker has been implanted correctly. And this is the tug test. We pull the tethers to see that the tug is good on the you see the tines, they are moving once I am pulling the thread, the tethers. So if you are seeing more than 2 times moving, you actually have more than 15 times the force required to pull it out. It is followed by the electricals, and if you see the ECG very carefully, the patient is having the wide QRS with the apical pacing, but narrower QRS when we are pacing through the leadless pacemaker, because we have placed it at the junction of the mid and higher septum. So this QRS results out very nicely. I was discussing with Dr. Srar, he's my mentor from Milwaukee, USA. He's designed a new 3D system, which is actually, it collaborates with the fluoro and gives us the conduction system in real time. So with that conduction system on 3D fluoro, we can actually place the leadless pacemaker on the left bundle. That is what they are working at. So all we know, this may be the next form of conduction system pacing that we have, totally going leadless, you know. He's looking at that future. In case we are not happy with the positioning of the leadless pacemaker, we can actually retrieve it out and, you know, we can take it back. As long as the tethers are in place, we can take it back and place it in a different position altogether. But once the tethers are cut, then we are done. So make sure that you have a good position before you cut off the tethers. This is our happy Micra team, and as of now, these have been the indications for leadless pacemaker. But in our country, the most important indication has been the infection. I'll just show you 2 or 3 cases to show you what actual place leadless pacemaker has in our country. I was lucky enough to do the first live case implant in June 2016 in TCT, India. For leadless pacemaker. Now this is the patient that we find. This is my maximum practice, you know, goes in this. Patients come with the infection from the transvenous pacemaker. This patient itself had a transvenous pacemaker implanted from last 2 years and is around with the sinus draining pus, and this is staph positive patient. We had explanted the device, the leads, and then implanted a leadless pacemaker here. Even in active infection, we have done it, and there has been no case report of infection on the leadless pacemaker. It is very safe to do it, that's what I can say. This is another patient who had a past history of CABG. He developed a complete heart block now. This was the kind of scars that he was having on the chest, all the keloids infected. He was scared to have a transvenous pocket. So instead of that, I gave him a leadless pacemaker, and there was no extra scar on the chest, so no scare of any infection. Now, in case you have a problem in the upper limb, many times we have a problem in the upper limb, we go through the femoral route and implant the leadless pacemaker. It has become our modality of choice. But what if you have a problem in the lower limb? This patient had an access problem in the lower limb. If you see, there is interrupted IVC draining into the azygos vein, draining into the persistent left SVC. Just look at the curve that the wire has taken, and that also still has reached the RA, not the RV. So we turned the tables. It was a lot of thinking which went by, and we turned the tables. Instead of femoral, we selected the jugular route. And once we selected the jugular route, actually taking the axis of jugular route was quite simple. But the mainstay came when we were actually dilating through the jugular route where to place the wire, because in case I place it in the RV, it will go through and through. So I placed it in the pulmonary vasculature and dilated the jugular axis very nicely. The sheath went in very nicely. But once the sheath was in, actually doing the leadless pacemaker through the jugular route was quite simple, but a little trickier. You were going through the right jugular, you would enter the CS directly. See, I go into the CS. I had to pull it back, place it, maneuver it a little, give it a clockwise twist, go into the right ventricular outflow tract, and then pull it down to place the leadless pacemaker at the RV septum level. And once it was done, the parameters were good, patient was ready to walk out of the hospital within 6 hours. Now, initially we had a single chamber leadless pacemaker. Now we have a AV micra, that is AV synchrony is there. So the algorithm works in form of A4, that is the atrial systole. When the blood is pushed into the ventricle, it corresponds to the A wave on the echo, and it has a 100 millisecond electromechanical delay. They label it as AM. The AV synchrony maintained in the AV micra is actually as good as the VDD pacemaker that we had. So it is about 80% of the time the AV synchrony is maintained. You have to control the rate to around less than 80, and then the AV synchrony is maintained very nicely in this. It's a similar procedure. There is no difference in the procedure. Only the thing is that instead of apical septum, I generally go to the mid septum or the higher septum, junction of mid and high septum to pace these patients. Again, 3 Tesla MRI compatible and 100% pacing more than 10 years. What is the future? What are we looking at in leadless pacemakers? Well, the future we are looking at is implanting 2 leadless pacemakers, one in the atria, one in the ventricle. This is coming, this has already started, the human implants have started already. The first implant was done in February 2022. This is from Abbott. This is known as AVR, and it is being done in Europe and US. India, it is not available as of now. It will be available by the second quarter of 2025. Then we will be implanting the 2 devices which will be talking to each other through the Bluetooth. So that's all. Thank you so much for your patient hearing. And I finished in time.
Thank you, Vanita. Please join us.